Today we have this young gentleman. He has got a right-sided moderate effusion, and we are going to do medical thoracoscopy with the help of a rigid thoracoscope. So the first and the foremost thing is we need to localize the site of entry, and every time we do a medical thoracoscopy, we always need to get the ultrasound chest done to find out the adequate site of entry. So you can see it's not visible. Now you can see that we are having a anechoic region. Now this entire thing what you are seeing as an anechoic region is nothing but the fluid. The first thing we are going to see is what is going to be the lower end. So here we have the diaphragm. So you can go a little up. Here you have a clear fluid. So we try to avoid the diaphragm as much as possible. So we are looking into the adequate site of entry here. You can see some cardiac pulsations, and you can see the jellyfish sign. I'm going a little higher to make sure that we are not going to touch the diaphragm. So here it is all organized. We are going one step down, and this is the site of entry. So again, if you go further down, we still have fluid. So we are in a safe area to enter. So I request my assistant to give me the needle cap. Yes. So we are palpating the intercostal space, and we are marking it. And again, we will reconfirm if we are in the correct space. Yes, we are in the correct space. We still have lots of fluid here, and it is going into a stage of organization. Now you can see that again we are able to. We are reconfirming the site. There's a clear fluid here, so we'll enter into space. We still have some margin here, so we still have a lot of margin to reach. Now we are going to clean and drape this area. We start with a circular motion. Lignocaine sensitivity testing. Give a lignocaine sensitivity. Now you can see that we have draped the area. Now we are going to infiltrate the skin with the lignocaine. So you can see stock of the fluid getting activated. So we know that we are in the space. Big. Look at them. Those blades. So now we are going to make the skin incision along the vein. Artery, third artery. You can see that we are dissecting the flash. Got the giveaway. We are aspirating the fluid. Take some. Now we have drained the fluid. Now as you can see from here, we are entering the pleural space through the trocar. So this is a 30-degree viewing telescope. So now you can see the parietal pleura, and there are a lot of nodules in the parietal pleura. So you can see the nodules in the parietal pleura. Looks like an abnormal pleura. And there are also some sort of pustules here, which are glistening. And now we will inspect the other pleural domains. So here you can see a lung which looks relatively healthy. And now as we go up, now you can see there is a lot of nodules which is glistening, and along with the cacheating nodules can be seen. So most probably it looks like a tuberculosis, and now we will take biopsy from these lesions and confirm. Now you can see that we are going for biopsy. This is a Thoracoscopy pediatric rigid bronchoscope, forceps. And now you have to be careful enough not to injure the parenchyma. Ma'am, apnea please.
Yes.
So now you can see from the So I am asking them for an apnea so that we avoid the lung. And now you can see that I am able to reach the nodule. It has to be in the proper vision. Now you can see that I am able to reach the nodule there. Hold it with forceps and I am peeling it off. Sister, ఒకటి ఫ్రోజన్ సెక్షన్ తీసుకోండి.
ఇది తీసుకోండి సార్.
ఆర్ మేము ఫార్మలిన్లో పెట్టండి తీసుకుంటాం నెక్స్ట్ చేస్తాను సార్. లేదమ్మా అది వేస్ట్ చేయదు. అప్నియా మ్యామ్ holding and feeling. ఇదేదో ఫార్ములా పెట్టండి. Look at the size of the pieces. Now the important thing is you don't injure the normal now. So always don't open the faucet. The faucet should be continuously closed till you reach normal. Take a biopsy from the posterior costal pleura. I'll come to the other side of the table. So, inside the pleura now you can see there are so many nodules in front of us. So, you can see like strawberry jelly nodules are there. Cutting the portion of it. కొంచెం సరైనలో కూడా తీసుకోండి జీవి. ఇది కూడా వస్తుంది కాదా? నెక్స్ట్ రెండు పీస్ ఫ్రోజన్ లో తీసుకోండి. So you understood now we are giving apnea so that we have space to work. If not, in constant pressure ventilation, lung will not collapse. Such a big one. The frozen thing. Now we will give apnea. See, now once we give apnea, see the lung collapses. Now you can see that we have connected the ICD to the water seal and there is collar movement. You should not have an active bubbling. If active bubbling is there, that means possibly you could have injured the lung. So be always cautious. So we have finished with the medical thoracoscopy. Now you have seen a case of medical thoracoscopy done with rigid thoracoscope. Thoracoscopy can be done either in conscious sedation or deep sedation or like this in a general anesthesia. We prefer to use a general anesthesia because we deal with rigid thoracoscope where we get a large chunk of tissues, and in case if you want to do additional lysis, we will be able to do it in the same setting. Certain precautions that are to be followed are it should be a strict aseptic procedure. So you need to take all precautions to avoid any sort of sepsis. Proper cleaning, draping is required. And during the introduction of the trocar, care should be taken not to injure the blood vessels. And once you are doing it under general anesthesia, as you would have seen from the video, whenever we wanted to take a biopsy, we make sure that we give an apnea time so that the lung collapses, so that we have enough space between the lung and the parietal flora to take a biopsy, and try to avoid taking biopsies in the intercostal space. Try to take the biopsies over the rib so that you can prevent injury to the neurovascular bundle. And once the procedure is done, make sure that the ICD is secured in place, and make sure a follow-up chest X-ray is done. And you need to look for any active air leak. If you have inadvertently injured the lung, you can anticipate an air leak. In this case, since we were extra cautious, we didn't injure the lung and we were able to avoid any sort of an air leak. And it is our practice that we send the tissue for frozen section to get an immediate diagnosis on table. And if it is a malignancy, sometimes we go ahead with an upfront IPC as well as a talc slurry. So this brings us to the end of this medical thoracoscopy with rigid medical thoracoscope. Thank you.